you for that nice introduction, Dr. Ayler.
I think that we're offline here. Let me see.
Are we offline? Yeah, thank you.
We're online.
Okay, all right. So I'll just get started. Just by way of outline, here are the things that we're going to talk about. We're going to talk a little bit about travel safety, traveler vaccinations, travelers' diarrhea prevention and treatment, and malaria prevention and prophylaxis. And I'm kind of going to limit it to that because this is a big topic. Whole textbooks have been written about travel medicine, and I can't, talk about everything in that time. And, what to do with the returning traveler who has fever, that's a whole separate issue. But I will kind of see what we can do for our pre-travel. And just as a disclaimer, the maps that I'm going to show are the most updated that I could find, but obviously as vectors move and, climate change happens, this will change. So you should seek from the CDC's travel website the most accurate information or the most up-to-date information if you're counseling either yourself or a patient. General approach to travel medicine concerns the vulnerability of the traveler, so host factors, what are they at risk for, just based on immunosuppression and those sort of things, underlying medical conditions, the risk of the destination. And the best way to get at this is to go to the CDC's travel website that I alluded to. It's cdc.gov/travel, and you can look up any destination in the world and see what diseases are prevalent there, and what vaccinations, for example, might be reasonable to offer. And then moving into the interventions, that's what I'm going to talk about most of this about, fill this discussion with. Another thing I won't be getting into a lot are, the specific diseases. I might go a little bit into how they're acquired, but I'm not going to delve a lot into, the specific diseases themselves. So it assumes you have a little bit of a background in that. So most travelers will want to come and talk to you and get your vaccines and get their malaria prophylaxis, and then you're going to have to kind of tell them that this is the way that most travelers get injured or ill, is through accidents. And so this should not be neglected. In fact, in a study in Jamaica between 98 and 2000, about 22% of the injuries or illnesses were from accident, whereas only 6% had GI-related illnesses in travelers. And cardiovascular was 4%. So travelers are going to get injured in car accidents. They're going to get injured in falls and all kinds of other things. A lot of times, alcohol use may play a role here, so you have to counsel them, don't do the things that don't do what you wouldn't do at home abroad, because you might be on vacation. There are differences in emergency medical services, so you're more likely to, have increased morbidity and mortality when you're overseas as well. And then some travelers are not able to wear seatbelts, either maybe the coach or van that they're driving in won't have seatbelts, so they should only, travel in vehicles that do have seatbelts. So, they have to really be picky. Basically, if you wouldn't do it here, make sure you pay good attention over there, because the mortality is going to be a lot more higher when you're overseas. They did a study between injuries in Ghana and Seattle, and there was a 6 times increased mortality in those injuries acquired in Ghana, just basically due to the medical care that was available there. Heat-related illnesses, especially heat stroke and just exhaustion and dehydration, especially for your patients who are on diuretics, and renal disease patients. And, basically just to use your common sense, don't go into areas that seem dangerous, and don't try not to be a victim of a crime and assault. And medical evacuation insurance, this is a good time to push that, because all travelers should have this type of insurance, because otherwise they're going to have a large catastrophic bill or not be able to make it back to the U.S. So moving into travel vaccinations, in general, just some general concepts. This is often not covered by insurance unless it's a vaccine that you should have gotten routinely and didn't get. May take weeks to months to complete, so a traveler might come to you a week before they're going to a far-off destination and expect to be all good. Well, they have to, they may have to give you a little bit more time, or you might not be able to finish the schedule of vaccines that are recommended. There are some accelerated schedules, especially for things like Hepatitis B, and keeping in mind, sometimes we have to give live virus vaccines. Those are contraindicated in pregnancy and immunosuppression. And you can give up to 6 live virus vaccines all at one time and still have efficacy and safety. But there's less efficacy as if you give, one now and then one 2 weeks from now. So you should either give them all on the same day or 4 weeks apart, separated. So getting into the specific illnesses and vaccines, hepatitis A is found throughout these areas here, mostly in the developing world. The incidence is about 20 in 1,000 in those who are going in more rural locations and adventurous travel, and about 3 to 6 per 1,000 to those going to more touristy locations. And this is just a generality. Obviously, different countries will have different rates. And definitely food and water safety would be another big thing to push in preventing hepatitis A. The vaccine for hepatitis A, the indications are, travel to areas of poor sanitation and health, those who have liver disease, clotting factor disorders, men who have sex with men, work with non-human primates, daycare workers, food handlers, and those exposed to sewage, and routine, it's now a routine childhood vaccine. So many of these folks should be getting this vaccine over here in the United States. They don't even have to travel to be candidates for it. There are 2 inactivated vaccines available, and the immunity lasts 25 to 30 years. The timing is ideally 2 to 4 weeks before travel. And then the adverse reactions, you can have some fever, injection site reactions, and headache. And as a caution, pregnant women and those lactating should be cautious with getting it. And anybody who has a severe latex allergy. So in the chart here, I put which vaccine could be safely given to those with a latex allergy, because the packaging contains latex and all the other ones. So that's the Havrix vial. So that's the one I highlighted in green there. So that's something that you should be aware of as providers. Moving on, Japanese encephalitis. It's fairly uncommon to get in travelers, but it's such a devastating illness if you do get it that it's worth getting a vaccine for if you travel to areas that are highly endemic for it. And as you can see, it's not just Japan, it's parts of India, Southeast Asia, Indonesia, etc. The reservoir are pigs and birds, and so if you go to farm areas, this is where you're more likely to be exposed. And the vector is a mosquito. So the risk is probably about 1 in 5,000 per month in some of the lower risk areas to up to 1 in 20,000. And if you're going, let's just say to Tokyo, for example, you don't need the Japanese encephalitis vaccine. But if you're going to Tokyo and then maybe you're going to go climb a mountain somewhere in Japan, that it's more close to the rural areas, you should be getting this vaccine or being offered it. There's one inactivated vaccine that's available in the United States. It's called Ixiaro, and you take 2 doses 28 days apart, so it does take a little bit of time to administer. It has a 95% immunogenicity. You should complete this. So you should start this 5 weeks before travel to complete those 2 doses. And you want to be finished 1 week prior to the travel at least. And then if you're still at risk, you should get a booster after 1 year. The adverse events are like with some of these other vaccines, pain at the injection site, headache, and myalgias. And the vaccine contains protamine, so if you are allergic to that, then caution there. And also caution in pregnancy. There's just limited data on the use in pregnancy. So the meningococcal vaccine is the next one. And the most endemic area is the meningitis belt of Africa. And the drier season, basically in June. Let me just see here. Whoops. So basically in the drier season in June is kind of when the nares dry out and the increased risk for meningococcus goes up. And the strains that are prevalent out there are ACY and W135. Also, if your patients are traveling to the Hajj or the Umrah in Saudi Arabia, they require this vaccine to go there. So the indications are the travel to that belt in Africa, pilgrimages to the Umrah and Hajj, patients who are asplenic, those with terminal complement deficiency, um, and it's now being given routinely to ages 11 to 12 with a booster at 16. The timing, you should complete it about 7 to 10 days before travel. And if you remain at risk, if you keep traveling to these areas, get a booster in 5 years. And these adverse reactions are going to sound about the same for most of these vaccines: injection site reactions, fever, and myalgias. And then the three vaccines that I highlighted in green are the ones that are for travelers. Um, and that's Menactra, Menimmune, and Menveo. That's because they protect against the serotypes that are common in that area. Now the Menimmune one is a polysaccharide vaccine, and that's specifically licensed for those above age 54. So if your patient is over 54, they should be getting that vaccine. And then the other two can be given to pretty much most ages. Now moving on to typhoid fever, similar to hepatitis A, is a disease of the developing world, also associated with poor food and water sanitation as well. And this is kind of a map of the highest risk areas, the highest being Southeast Asia. The typhoid fever vaccine, there are two vaccines available. One is the Vivatif, which is an oral live vaccine, and obviously this should not be given to those who are immunocompromised. It has a lot of things you should know about it, like it needs refrigeration, it should be taken once every other day, and you should complete it 1 week before travel. And it requires a booster in 5 years, whereas the other vaccine you can boost every 2 years. So contraindications would include, a young age, less than 6 years old, the immunocompromising conditions that I've already discussed. Taking it within 3 days of having taken antibiotics reduces the efficacy because it does contain live bacteria. So you shouldn't take it then. And then chloroquine, mefloquine, and proguanil, all for malaria prevention and prophylaxis, they have like somewhat of an antibacterial effect as well. So taking those with the vaccine reduces its efficacy too. Adverse reactions would include fever, headaches, nausea, vomiting, diarrhea, and rash, but are pretty unusual. And then the intramuscular vaccine is just one dose right before you travel. Like I said, boost every 2 years, and you want to complete it 2 weeks before travel. So if the person's traveling, it doesn't give you much notice, they may have to get the oral vaccine if they have no contraindications. And adverse effects are similar to the other injectable vaccines that we've already talked about. Now, yellow fever is a vector spread virus spread by certain mosquitoes, and there are not a lot of cases of this, but it's sort of like Japanese encephalitis. It's a scary enough disease to where if you do get it, the mortality is pretty high. So that's why we do vaccinate against it. One study shows that between 1970 and 2013, there were only 10 cases in unvaccinated travelers from the U.S. and Europe. 5 of those were from Africa, and 5 of those were acquired in Central or more like South America. The risk in West Africa is much higher, about 50 per 100,000 to get ill, and 10 per 100,000 to die. And then in South America, that's contrasted with 5 per 100,000 and 1 per 100,000, respectively. So the yellow fever vaccine is a live attenuated vaccine. You boost it every 10 years, and it has some very serious side effects which increase with age. The side effect profile that's most concerning is called yellow fever viscerotropic vaccine-associated viscerotropic disease. And it's basically kind of a infection with yellow fever virus. And you can have fever, myalgias, rhabdomyolysis, thrombocytopenia, lymphopenia, disseminated intravascular congestion or coagulation, hepatitis, oliguria, and multi-organ failure. And this usually begins an average of 4 days after getting the vaccine. There have been only about 65 cases since 2001, since this was recognized as an entity. And then as you get as you get older, this becomes more of the risk of getting this goes up. So age 65 to 74, there might be 3.5 cases per 100,000, and age 75 and older, there are 9 cases per 100,000, so it almost goes up 3 times. And if you were to want to diagnose that, you would actually do like a PCR in tissue or in blood for the yellow fever virus, actually. So hopefully, really you have to counsel your patients, and select the best ones to get this vaccine. Contraindications would include like a young age, less than 6 months, symptomatic HIV infection or those with a CD4 count of under 200, thymic-related disorders, primary immunodeficiencies, malignant neoplasms, transplantation, and immunosuppression or immunomodulatory therapies. And some of these are going to have to be kind of a risk-benefit. Is the area that you're going risky enough to warrant getting this? And then precautions, certain age groups are precautions rather than absolute contraindications. Controlled HIV, where you're between 200 and 499, that's more of a kind of a case-by-case basis. Pregnancy and breastfeeding, in general, the vaccine, may be reasonable to give to some pregnant women and some women who are breastfeeding if they're going to an area that's highly endemic or risky. There are certain countries that require proof of yellow fever vaccination from all arriving travelers, or they require a yellow fever exclusion letter. So either written on letterhead or put into the yellow card part of the vaccination book. And ideally, you should get one of these every time you travel, so you can't get a blanket one for your whole life. So this increases the travel medicine clinic's business, right? You should get a new one each time. And there are certain clinics that are only able to offer the vaccine, so you actually have to get something from either the health department to basically say that you're qualified to give this vaccine. So not every place has this. This is the medical contraindication page here. Now moving on to the rabies vaccine. Rabies is more common in these areas with the reddest on the map. Those are the areas where dog rabies is the most common, probably. And only certain people, will generally need to get the rabies vaccine before they travel. Those are people who are going to work with animals, so like wildlife photographers or, biologists, let's say. Travel to remote areas with very limited medical care. Travel greater than 1 month where dog rabies is common. And children, they say, possibly, because they're less likely to report bites, and they're more likely to get severe bites either on the face or the neck. And it really you have to take into account, how good is the medical infrastructure where your patient is traveling to. There are 2 vaccines. One is called the human diploid cell vaccine, and then there's the purified chick embryo cell vaccine. And the schedule is 0, 7, 21, or 28 days, so it takes 3 to 4 weeks to complete before they go. And if they don't complete the full series before they leave, they basically need to be treated as if they never got the vaccine, if they were to get an exposure. So really it's best to complete all beforehand, although you will get probably some immunity with a partial vaccine, but you can't assume that they're immune. The timing takes 3 to 4 weeks to complete, as I mentioned, and then who needs a booster? So veterinarians here often have to get this vaccine, and they have a test where they basically measure their rabies virus neutralizing antibodies, and it's called the RFIT, or the Rapid Fluorescent Focus Inhibition Test, and they usually get it every 2 years. Not every lab does this, so it may take about 4 weeks to get a result, and so if you're trying to get this right before somebody's trying to travel, it might slow things down. And the level should be greater than 0.5. Yeah. Oh, great. Okay. Great. Well, thank you for adding that. And then one of the last vaccines I'll talk about is the cholera vaccine. which is not available in the U.S., but there are a lot of countries in which this is endemic, also in Haiti, which is the closest to us, and it may only be more relevant to some people who are going on medical missions or going to the most rural areas or where there's an active cholera outbreak. There are two vaccines that are not available here, so I'm not going to go through a lot of the details. But these sometimes you may recommend that the traveler get this in their destination country if you think they're at significant enough risk. Interestingly, it actually provides some protection against enterotoxic E. coli, maybe about 67%. So that's another little benefit to it. They should also kind of receive all their routine vaccines before going, and this is where accelerated schedules may be helpful. And then the ones I would focus on is the polio vaccine. Only a couple countries now still would require this, according to the World Health Organization. If you're traveling to the Hajj or the Umrah again, you still need to show proof of this. And if you haven't completed the 4-dose series, basically you need a booster if it's been more than 10 years. And this is an older map, so I X'd out Nigeria here, so Nigeria is okay now, and Afghanistan and Pakistan are the ones where you would need to get the polio vaccine before going to. And obviously Saudi Arabia if you're going to the pilgrimages that I mentioned. Now moving on away from vaccinations to travelers' diarrhea. This is kind of a map that shows the incidence of travelers' diarrhea and where it's more prevalent. This is from an article by DuPont and Stefan and others and JAMA. And I think Kelly Keniston talked about this in one of our journal clubs once, so it's a very good review about travelers' diarrhea. So in terms of prevention of travelers' diarrhea, there's certain things you want to counsel your patients about: avoiding uncooked vegetables, raw fruits that are eaten unpeeled, so bananas and those sort of things are okay. Unpasteurized fruit juices and milk products, undercooked meat and seafood, the use of ice, and then food from street vendors. You should try to avoid all those if you really want to be the safest. And do definitely counsel your patients to wash their hands well with soap and water. Alcohol-based sanitizer can help some, but doesn't help with things like cryptosporidium and norovirus, for example. And then boil or filter the tap water, which would be ideal. But also if you make it too hot to the touch, like let's say with tea or coffee maybe, you do get some protection from that as well. There are some disinfection tablets that they offer, like chlorine-based ones and iodine-based ones, and caution with the iodine and thyroid disease, patients with thyroid disease. Somebody who has real thyroid issues should only take it for a week or two probably, not for months. Eat food that's served piping hot, and then beverages that are served steaming hot like coffee and tea are okay again. And I should mention those, the iodine tablets also not for women who are pregnant because the fetal thyroid tissue can take it up very, very well also. And actually, they make a mention that in some of the resources I was reading that drinks containing alcohol do not always kill off all the bacteria. So, yeah. So it depends on what you're drinking there. Yeah. So there are a lot of options. There are a few options for prophylaxis for travelers' diarrhea. Things like bisthmus would be helpful. There are tablets of bisthmus that you could take. Issues, are that it turns your stool black. You can get tinnitus if you get too much of it. And then you should avoid it with patients who are also on high-dose aspirin or sometimes even a bit of aspirin because it can lead to salicylate intoxication or poisoning. The efficacy is maybe about 65% in some studies. Cipro is another possibility, but it does have the risk of antibiotic resistance and C. diff, tendinitis, QTC issues with cardiac conduction abnormalities. And then you should probably only limit it to about 2 to 3 weeks if you're going to give this to your patients, but it is probably the more effective prophylaxis to be given. In general, they only recommend prophylaxis for those where basically the purpose of the travel would be entirely disrupted by just a couple days of diarrhea. like perhaps a honeymoon, for example, or an important business trip, or one of those sort of things. And then lastly, rifaximin is very expensive, but it is available, and it's, you can see its efficacy there, maybe about 48%. Now, what you may choose to do rather than prophylaxis is to give your traveler a treatment for traveler's diarrhea that they're to take, if they do get diarrhea, it's kind of to take it when they first start getting it. If they're having fever greater than 101.3, or they're having bloody stool, they should really seek treatment though, and they should avoid using loperamide in those cases. Bislimus, just at the same prophylaxis dose, can really be used to treat traveler's diarrhea. Loperamide can be used with those exclusions that I mentioned before. Cipro can also be used in a 1 to 3 day course. And it's really your first choice, except if you're going to South or Southeast Asia, because there you do have a lot of, Campylobacter, Cipro-resistant Campylobacter, and some of the other bacteria getting more resistant in that area as well. Rifaximin can also be used, but it's not really for invasive pathogens, because it's actually not an absorbed antibiotic. It's just a luminal-acting agent. So you wouldn't want to give it for, it's not going to protect against Salmonella or Shigella or Campylobacter as well. And then azithromycin, which is really your drug of choice for those traveling to South or Southeast Asia, can get some nausea and some QTC issues with that drug as well. And that's a pretty short course as well, either a gram times 1 or 500 milligrams for 3 days. Now moving on to the last topic, malaria. Malaria is found endemically in all these countries in orange here. And you really have to tell your travelers about the ABCs of malaria. Be aware of, that you're traveling to an area where it's endemic. And even those who are from those areas but have moved away for several years are still at fairly high risk, almost as high as, people who have never been there. So you have to be aware that you're at risk. Avoid bites, so the hours of feeding are important. From dawn to dusk, the mosquitoes for dengue, yellow fever, and chikungunya feed. And from dusk to dawn, malaria, West Nile, and Japanese encephalitis. And these are just generalizations, but it can be somewhat helpful. And really, you should use protective clothing, long sleeves, repellents with DEET, and permethrin impregnated bed nets or clothing. And there's ways to basically either spray your clothing with permethrin or to put it in a bag and kind of coat it very well. And then lastly, or second to last, taking chemoprophylaxis if you're going to a risky area. And then if you have a fever, seek diagnosis. So that's really important. So chemoprophylaxis, if you're going to a chloroquine sensitive area, chloroquine is recommended, usually 300 milligrams once a week, and you want to start this a couple weeks beforehand. It's contraindicated with those with glucose 6-phosphate dehydrogenase deficiency, and if you've gotten the live oral typhoid and cholera vaccines 3 days prior, you just want to wait to take it until after that. It's safe in all ages and in pregnancy, and I think I remember this being like a board type of question in some settings, which is the best chemoprophylaxis to give to pregnant women. And then it can cause pruritus, actually more in dark-skinned individuals, and exacerbate psoriasis as well. If you're giving, I didn't mention this because it's not really like FDA approved, but there's an intradermal pre-exposure rabies vaccine, and the clinic actually has to use that vaccine very quickly. It only has like a 6-hour shelf life, so it's not done very often. But if you're in a clinic where you do give the rabies vaccine intradermally, it can suppress the efficacy of that. It doesn't really affect the intramuscular one. It can cause issues with QTC prolongation, shouldn't be co-administered with antacids, and it decreases the absorption of Cipro and can change digoxin levels, just to say a few drug interactions. These are the areas where chloroquine resistance is common, and the chloroquine-sensitive areas are the ones I'll highlight, and those are the ones on the left in Central America and little parts of South America and the Caribbean. And pretty much everywhere else, you're not going to use chloroquine. So if we're talking about prophylaxis for chloroquine-resistant areas, then we're going to other drugs like mefloquine. It has a very long half-life, so you're going to want to start about 2 weeks prior, and you also want to see if the patient tolerates it, because about 25 to 50% of those on mefloquine, have some sort of side effects from it. Those include, worsening of psychiatric disorders, up all the way going to psychosis. It is contraindicated in those with seizure disorder or major psychiatric illnesses, especially. Causes a lot of dizziness, vivid dreams, can inflame the liver, QTc prolongation, and a lot of just nausea and vomiting, and some diarrhea too. There are interactions with warfarin and cyclosporin, just to name a few as well. So that's one option. There is and I alluded to its very long half-life. You have to kind of take a loading dose if you really want to get good levels, or you should take it a few weeks beforehand. So if you don't have a lot of time before travel, you could take a loading dose once every day for 3 days before traveling, and then you're just going to take it once a week. And that's probably enough time to figure out if you're going to tolerate it well or not. One of the more tolerable medicines, doxycycline. The good thing about it is it also prevents leptospirosis and rickettsial disease for those going on big backpacking trips throughout heavily wooded areas. The timing, you just start a couple days beforehand, and it's a daily medicine. And I didn't allude to this with mefloquine, but you need to take these both 4 weeks after you return home. So that's one of the drawbacks of these medicines, is that they don't kill the liver phase. So you have to take, once you leave the exposure area, you need to kill the liver phase of the parasites. It's contraindicated in those less than 8 years old and pregnant women, and then can cause some photosensitivity. So this is definitely one where you would have to wear your sunscreen and counsel your patients appropriately. And can cause some GI side effects as well as C. diff. Primaquine is the drug of choice for Plasmodium vivax. To prevent, you want to start 1 to 2 days prior. The good thing about this is a daily medicine as well, and the good thing about it is that you only need to take it 1 week after, because it does kill the liver phase of the parasite. It's contraindicated though in G6-PDH deficiency, so you really have to do a test before you would prescribe this. Also pregnancy and breastfeeding, there's a caution as well. And then the major adverse events are GI side effects. And then lastly, probably the best tolerated one is atovaquone proguanil. It's usually the more expensive one, but also you only start it a couple of days beforehand. It's very, very, very easily tolerated by most folks. And then you still take it just 1 week after travel, after returning home. And caution in pregnancy and breastfeeding and severe renal disease, usually with the eGFR less than 30. And has some mild GI side effects in some individuals. So that's pretty much it for your malaria prevention. Hopefully you've learned something about traveler's diarrhea, malaria prevention, and prophylaxis, and vaccines. These are some other resources where you can go to find out more. The cdc.gov/travel, which I think really should be your first stop. And there are links to the CDC's Yellow Book, which was helpful for making this presentation. There's a World Health Organization version of the Yellow Book as well. I also looked into Essentials of Travel Medicine for some of the information here. There is a professional society, the International Society of Travel Medicine, where you can look to find a provider in your area. And then I put the reference for the Traveler's Diarrhea article as well.